Hello and welcome to today's Power of Knowing webinar. When is hospice the right choice? Understanding the benefits for patients and families. Understanding comes from knowing. Many people have heard of hospice, but few fully understand the comfort, dignity, and support it provides for individuals living with a terminal illness and for their loved ones. Hospice care is more than medical support. It's a holistic approach that includes emotional, spiritual, and practical guidance during one of life's most challenging times. This webinar will provide clear, compassionate information about what hospice is, when it might be the right option, and how it can enhance quality of life for both patients and families. You'll also learn about eligibility, costs, and how to begin the conversation about hospice care. The Power of Knowing is a free webinar series created by AuthoriCare Collective, a nonprofit organization that empowers people to be active participants in their care journey, enabling them to live on their own terms through personalized support for mind, body, and spirit. To get us started, please welcome our moderator, Risa Hanau. Risa serves as clinical and community educator at AuthoriCare Collective and is also a member of the Cone Health Ethics Committee. She's a licensed clinical social worker. Risa, I turn it over to you.
Thank you, Paul. It's my pleasure to introduce our panelists for today. Tracy Ennis. Tracy has over 34 years of nursing experience. She brings rich and diverse clinical background that spans intensive care, emergency medicine, research, labor and delivery, and gastroenterology. Tracy joined AuthoriCare Collective in 2016 as an admissions nurse, and since then has held key roles both as a community liaison and a hospital liaison, and currently is the Director of Hospital Services at AuthoriCare Collective. Tracy earned her Bachelor of Science in Nursing from Oregon Health Science University. And Gail Scott. Gail has over 25 years of experience in hospice and end-of-life care, caring for individuals and families. Gail has a particular interest in advanced care planning, grief and loss. She is a licensed clinical social worker who holds a master's degree in social work from Virginia Commonwealth University, and at AuthoriCare Collective is our Director of Social Work. Gail also has personal experience as a family caregiver for a parent living with dementia. Thank you both for being with us. We also would like to know some about who is joining us, our participants. So when you participate in our polls, know that they are anonymous. We invite you to look at your Zoom screen. The first question, who is here today? Go ahead and answer all that apply to you. It is multiple choice, so you can choose all of those. The second question is, whether are you or a loved one yourself facing a life-limiting illness? And then the third question is whether you signed up for today's webinar to learn more about services because of a current medical condition or a concern that you might be having. Thank you for taking a moment and see the numbers going up, and really appreciate you responding to that. So we have really a broad swath of people joining us, many caregivers, advocates, healthcare professionals, human service professionals, and we know many people serve many different roles. Then we do have about 20% of people who are currently facing an illness themselves or a loved one facing a life-limiting illness. And then we have about 40% of people who have joined because of a particular situation. And thank you both for sharing that and for joining us today. It's certainly meaningful for us to have this conversation. Unfortunately, Tracy, I think conversations sometimes don't occur until we're in a point of crisis. And for us to be able to have a conversation today, please know our participants, you can put a question at any time in the Q&A, and we will try to answer as many of those questions as we can during our time together. We also have an opportunity. Everybody registered will get an email tomorrow with access to the recording, some resources that will be useful, but also the ability to respond to that email if you have additional questions that we did not get to today. But Tracy, to start us off, I know you do this every day, and I'm sure the conversation changes depending on the situation. But if you were going to give us a broad definition or overview of what is hospice, as we said in the introduction, many people have heard of it, but very few of us have a complete understanding of it.
Thank you, Risa. Hospice is a comprehensive approach to caring for a patient and a family, or anybody we call family, that is facing a terminal illness. Medicare states that that diagnosis, we would consider that that person would no longer be with us within a 6-month period of time, should that disease follow its natural trajectory. Sometimes patients do well with hospice and are on services longer than that, but initially, when we first look at it, the diagnosis is our determining factor. The comprehensive care is a team that is caring for that patient and family. So we are the medical director who's helping to guide that care, or the primary care physician, a nursing case manager who is responsible for visiting that patient, kind of depending on how that patient is doing. So if they're having a great week, we might see them 1 to 2 times. If they're not having a great week, we might see them every day. But in addition to that, we also have on-call nursing, that anytime there's a question or a concern, a patient or family member can pick up that phone, call our on-call services. Many times we can manage things over the phone. If we can't, then we have a nurse that can come out regardless of any hour of the day or night, and regardless of the day of the week. We also have nursing aid services to assist with being able to care for that patient and keeping them physically comfortable and clean. That is usually something that starts off just a couple of times per week and then can increase if need be for that patient and family. We have social work services that can help provide community resources, also advocacy and any conversations, and help with any end-of-life planning. We also have volunteer services for when patients may need assistance with maybe a caregiver that needs to sit with them. Maybe somebody needs to go and pick up prescriptions. Maybe we need to get groceries, help with getting groceries. Pretty much anything that you can ask, we will try to find a way to meet that need for that patient and family. And then, of course, we have our spiritual care services, not to replace anything that you may already be connected with, but an additional layer of spiritual care specifically around end of life. If I had to sum up what I thought hospice care is and is done well, that it's not about dying, it's really about living well. And following a quote or offering a quote from Dom Cicely Saunders, "You matter to the last moment of your life, and we'll do all that we can not only to help guide you to die peacefully, but to live well until you die."
And it's a It's a beautiful quote and it sums up very much about the work. I want to, you've given us a lot of information, and I want to go a little bit deeper with some of the specifics. And Gail, when Tracy said that somebody has a terminal illness, that's number one, very hard to hear. That can be hard to understand in terms of what types of illnesses. I mean, it is the case that hospice cares for people no matter what the diagnosis is and no matter what the age of the person and even where they reside, as long as we can care safely. Can you talk to us about some of those things?
Sure. Thank you, Risa. And as you mentioned, hospice care is available regardless of diagnosis. Oftentimes, we think of a person receiving hospice services who may have a cancer diagnosis or a heart disease, a diagnosis of heart disease, or some type of cardiovascular disease or lung disease. And certainly, we have many patients that we serve under hospice care who have a dementia diagnosis or Alzheimer's disease or some cognitive impairment diagnosis. So, diagnosis does not matter. Hospice is available to anyone, regardless of what that diagnosis may be. And it is care. I'm so glad you mentioned, Risa, that it's care that's provided regardless of where the individual resides. I think a common misperception sometimes is that hospice is a place and that when you are admitted to hospice services, you have to go somewhere. But one of the things that I have long appreciated about hospice is that we serve individuals regardless of where they call home. Most of our patients are served in their own private home, as well as in long-term care facilities or assisted living facilities, family care homes, group homes. Yes, we do have uh, two hospice inpatient facilities, one in Greensboro and one in Burlington. However, the majority of our patients, or the majority of patients in general served by hospice, are living in their own home. The decision so a person who has any diagnosis that may be considered terminal, uh, and a terminal diagnosis, or when that diagnosis is made, is not necessarily the moment that someone always is referred to or admitted to hospice. Sometimes it's a period of time following the diagnosis. And the decision or question about when is hospice appropriate or when is the right time for hospice, it's a very difficult decision for one to face often. And there are many factors, many considerations, both medical as well as personal, in regards to when is the right time for hospice. Certainly, there is that criteria of a terminal illness with an expected prognosis of 6 months or less, which is an average. As Tracy said, we have many patients who live well beyond 6 months, and we have many patients under hospice care who may not live for 6 months. But there are a number of factors to consider related to when is the right time for hospice, and it's always a choice, and it's always the individual's decision about when they perhaps may not want to continue pursuing treatment that is not compatible with hospice, more aggressive or curative treatment, when a person may be having many symptoms, that there's a need for assistance with symptom management. When a person decides to shift a focus from treatment and going into the clinic or the doctor's office or multiple hospitalizations and wants instead to stay at home or focus on comfort care and quality of life, as Tracy said, living fully. And then there's also emotional or personal considerations related to how you want to spend your time, spending time with family, which often can occur more so in the home environment, as well as when individuals or caregivers may feel particularly just overwhelmed by all that they are facing in regards to visits, physician or provider visits, and hospitalizations and treatment.
Thank you. That's very helpful, and it leads, I think, to further conversation, Tracy, when we say somebody has a terminal illness, so we can say somebody is medically eligible, and that means that according to the guidelines that Medicare gives every hospice, that every hospice has to follow, that a physician is saying, I believe if this illness continues to progress, that the lifespan is limited to 6 months or less. But as Gail noted, there is also the other piece that people are not continuing or are not seeking what sometimes is called curative, sometimes aggressive. It's a hard word to parse out. But what does that really mean for somebody looking at the recommendation for hospice services in terms of what kind of care they may decide to no longer pursue, but what kind of care are they still going to continue to receive?
Sure. Thank you, Risa. That's a really good question because I think oftentimes people think, oh, I've decided on hospice. That means I'm dying, and I'm dying right now. And possibly I think a common myth or misbelief is that people think hospice is going to come in and help hasten my death. That is not the case at all for hospice. Again, hospice is for living fully. Um, in terms of looking at not continuing treatment, so Medicare says that if you're going to choose a hospice focus, that you are choosing not to pursue continued curative treatment, that you're asking and requesting to focus on comfort. Comfort doesn't mean stopping everything so that you don't receive any treatment. In the terms of, you brought up cancer. So with cancer treatment and hospice, it does mean that you can no longer choose to pursue chemotherapy or radiation treatments. Um, Oftentimes we will see somebody that's referred for hospice that is still undergoing what's considered palliative treatment. And what that refers to is that the treatment that they're receiving is hopeful to not necessarily prolong the life, but aid in symptom management. And that's perfectly acceptable in prior to accepting hospice, but we would usually not enroll somebody in hospice services until that palliative treatment is completed. Um, in terms of heart disease or other disease diagnoses, it is really a case-by-case basis. There are many medications these days that patients are treated with for heart disease that help the heart to function better. And it used to be believed that that hospice would not cover that. We do cover those things. We again are looking at maximizing quality of life. We do not consider medications that are considered to be life extending, but definitely working on quality of life. We also add medications. Let me first refer to, we may take medications away that historically a patient may have been on, but now, because of the disease that the patient is encountering, may actually be more burdensome to the body. And so we may take some of those away, and then we add medications when appropriate for symptom management. So if a patient is having pain, we can come along and help with pain management. Symptoms can include shortness of breath, nausea, vomiting, emotional and physical pain, delirium, um, anything that is bothersome to that patient, we can help come along and support both medically, pharmaceutically, but that's the beauty of the team is that we also have social workers and spiritual support because many times our symptoms arise from something other than physical.
So Gail, talk to us a little bit about, I mean, I think most of us, particularly when we think about a diagnosis, we think about end of life, it feels very medical, very sterile, but it's very emotional. It's very much an individual, a family experience. And talk to us more about the team. And as Tracy said, if somebody has a symptom, why it is that it might be the spiritual counselor or the social worker or the volunteer that's a veteran, just like the patient is, that might help bring comfort and enhance the quality of life along with that medication that might be offered.
Thank you, Risa. I'm so glad that you asked this question because the interdisciplinary team approach to care that hospice provides is unique. And it is what I personally have always uh, appreciated and felt most passionate about in regards to hospice care. It is truly whole person care, mind, body, spirit, holistic care. Often we say, or hospice is referred to as holistic care. And it's a team approach to care, as Tracy mentioned, a nurse who is certainly attending to physical needs and assisting with pain and symptom management that may be physical in nature, a social worker who expertise is connected to the emotional part or coping uh, with the illness, the diagnosis, with the grief, the anticipatory grief we call it, associated with disease progression for both the patient and the family and caregivers, and then our chaplain or who provides spiritual support and spiritual counseling related to those questions or needs or uh, perspectives that arise when people face their own mortality, and also for caregivers there again. And hospice care is not only care for the identified patient, but for the family, whatever. I think Tracy said this at the beginning, whatever family is to that individual. It could be a traditional family, a mother, father, children, adult children, grandchildren. It may be an individual who lives in a neighborhood and just has tremendous support and connection to their neighborhood or community that's pulling together to support them and care for them. And so all of this care is for certainly the individual who has been referred to and admitted to hospice, but also to their support system. And that's one of the first things that we do when someone is admitted to hospice is to assess who is important to them, what is important to them, but also who is important to them, who can they rely on for the support that they may currently need or that they may need in the future, and also assisting in identifying a support system if an individual is uncertain of who that would be or what that would look like.
Thank you. And when I think about that team, when I hear spiritual care, I want to just really think about this is not from a particular religion or a particular faith perspective. Am I correct in that the chaplains are visiting in a non-denominational, if nature is what fills my cup rather than formalized religion, that might be what the chaplain is coming to work with me on.
Correct. And the team involvement is on the terms of the individual and what their choice or needs are. Uh, Certainly, we feel that patients and families always get the best that we have to offer when they uh, receive or accept the entire team, include and not just nurse, chaplain, social worker, but also our wonderful home health aides and volunteers and providers. We always feel that individuals receive the best care when they are accepting of the entire team. However, it's always the individual's right to receive any member of the hospice team on their own terms and according to what they perceive their needs to be.
And I know when we begin to provide services, we initially gather information about who you are, tell us your story. So if somebody had been a veteran, the care really is tailored to that individual. It's not tailored to a diagnosis, but perhaps there are particular things about that veteran's experience that will guide the team in the way that we provide care. And tell us a little bit about how the care is individualized, albeit some people have similar diagnoses.
Well, you mentioned veterans, and I'm proud that part of our care that is veteran centric, and we participate in a program that's a partnership through the Veterans Administration and the National Hospice and Palliative Care Organization, which actually has a different name now. I won't use our time trying to remember what that is off the top of my head. I think the Alliance uh, for Home Care Hospice, something like that. But anyway, we have a partnership where we provide veteran-centric care and really want to learn about the military history and service of those individuals that have served and how they would like their care to be provided according to what their service means to them or how it has impacted not just their life, but the life of their family members. And then, of course, according to diagnosis, we're looking at assisting in building up caregivers. One person with a certain diagnosis might need a lot of assistance with personal care or caregiving. Another diagnosis might be, or the same diagnosis, another patient might be more independent and may need more education just around what to expect, uh, or for the future. But we do provide individualized care, and that's just core to our mission and service.
So Tracy, I want to go back and think about some of the particulars to our service. You named this team. And the fact is that most people are living at home or they're living in a long-term care or a residential care facility. We are not there 24 hours a day unless somebody is there in one of our two inpatient hospice units. But we've got that team. And we also have, as a part of the Medicare benefit, other parts to that benefit, like supplies and equipment. Tell us about some of the other things that are offered. And then I want to talk about how it's paid for.
Sure. I'm thankful, Risa, that you brought forward that we are not 24-hour caregivers in the home. I think that is another common, excuse me, myth that patients or families may perceive. And what we do as an interdisciplinary team for patients in the home setting or an independent living setting, long-term care setting, we are the team that's coming along and helping support caregivers, whoever that caregiver may be, or whoever that caregiving team might be. So if it's family, we are there to help support and provide education around caregiving for somebody, whether it's medication administration, bathing. Now, our hospice aides, our home health aides do come in and help physically do those kinds of services if need be to a specific care plan. But we're not there every day, so we do assist families in learning how to provide that care, turning a patient well, transferring a patient well, um, helping recognize signs and symptoms of discomfort. Um, in the long-term care facility, you have caregivers that are caring for that patient. But again, the hospice team, the interdisciplinary team, supports those caregivers and the family as well. That caregiving team that's already in place at a long-term care facility becomes part of that hospice benefit recipient. Um, in our inpatient units are very short-term units. We are not residential long-term care. So patients do not come in with a hospice diagnosis to stay with us until end of life. Our inpatient units, as Gail mentioned, we have two, one in Greensboro and one in Burlington. You may have heard of them, Beacon Place and Hospice Home. They are really used for two different scenarios. One being short-term symptom management. So if a patient perhaps is in the hospital and the hospital hasn't been able to get their symptoms under control, they can admit directly to one of our inpatient units so that we may get their symptoms under control and then help transition them back to the setting that they call home. Patients who are at home, and if we are unable to get their symptoms well controlled with all that we have to provide in the home setting, we can also transfer those patients to our inpatient unit to provide short-term symptom management rather than having that patient have to go back to the hospital setting, where it's much more aggressive, more diagnostic. So you have to endure a lot of things that are not comfort focused when returning to the hospital. We would never tell a patient that they can't go back to the hospital, but we ask that patients reach out to us first so that we may help them avoid a hospitalization if at all possible. And then our inpatient units are also for a setting for true end of life. Patients who may be expected within hours, days to pass. And so, and families and patients would prefer for that patient not to pass in a hospital setting or pass in the home or in a long-term care facility, and ask to be surrounded by that 24-hour a day interdisciplinary team that can care for them one-on-one.
And I'm thinking about how what my wishes may be when I begin to have services over the course of weeks or days. My decisions might change about whether I do want to meet with the chaplain to work on funeral planning or where my desired location of death, because we know people's stories really change and unfold as they experience the progression of illness, and also for those who are taking care of them. So I think, Gail, that goes back to that individualized care that we're providing. And talk to us some about in addition to the people, the other things that are being provided in terms of equipment and medication and that make up this benefit and are adjusted as somebody's needs change. Gail, you're on mute.
Oh, I'm so sorry. And I did not realize I had put myself back on mute. So thank you, Risa. And you've mentioned the hospice Medicare benefit, which some of our audience may or may not be aware that Medicare does have a hospice benefit, as does Medicaid and many private health insurance plans. However, and we do provide services. Hospice services are provided to anyone, regardless of whether they have Medicare, Medicaid, or private insurance, or insurance at all, or ability to pay. However, generally, under the hospice Medicare benefit, for example, in addition to this wonderful team care that we've been talking about, there is the benefit of receiving uh, assistance with paying for your medications, supplies, things like we call them chucks, under bed pads that are often found on hospital beds or in a chair where a patient may sit if needed, briefs, adult diapers, gloves, things that the caregiver may need to provide care for the patient, gloves, uh, and many other supplies are provided by hospice, as well as what we call DME, or durable medical equipment, which could be a wheelchair or hospital bed. Also oxygen, if that is needed under the uh, and it's also provided under the hospice Medicare benefit. And whereas with some plans and traditional Medicare, some of our audience may be familiar with, maybe from prior need, there certain criteria has to be met in order for Medicare or insurance to pay for a hospital bed, for example, or for a person to qualify for oxygen in the home. Under hospice care, there does not have to be any criteria other than the team and it's requested by the patient and caregiver or family, and or the team feel that it would be something that would make the individual more comfortable. So there's not specific criteria that has to be met in order for a person to have a hospital bed. If that's something that would make them more comfortable, having a bed that they could elevate or adjust for a more comfortable sleeping position, that's provided under hospice care. And it's not a one and done, that when you're admitted to hospice and you say, I don't want a hospital bed, that doesn't mean that you're not ever able to receive a hospital bed over time. And as you uh, as needs change, we can place equipment or this durable medical equipment in the home, or we can provide supplies in the future that may not be needed at the start of care.
So, Tracy, thinking about start of care makes me think about, I know one belief that many people have is that only a physician or a provider can make a referral or start the conversation. Um, Tell us about how any person can start the conversation about hospice, and what are some of the reasons, or what are some of the changes that might be going on for somebody to think maybe now is the time for hospice, albeit that can be difficult, but what are some things that might be going on that people might notice?
Thank you, Gail. I mean, Risa, I apologize. And thank you, Gail, for your explanation. You had asked me that question, Risa, and I didn't address it. And I think one piece that we've not addressed, and I just want to make sure that we do touch on, is we did hit about the interdisciplinary team and durable medical equipment. But one of the other benefits of hospice is medications. So we touched on the fact that, we may take some medications away and we may add some medications, but that is also part of the hospice Medicare benefit, is that medications are paid for by hospice. We don't do long amounts of them because we are certainly working on comfort-focused care, but we do provide medications as part of that benefit. So when is the time for hospice? For each person, that can be very different. Patients may receive a diagnosis, perhaps cancer, that they decide, I don't want treatment, I don't want to have anything, and that is perfectly appropriate. And we would like to see patients earlier in their prognosis, because it allows us to provide that wonderful support for the patient and family and get to know what their desires are as they travel down that road and are on that journey. For some patients, it may be that they've been through treatments and they're tired and they just don't want to do any more. That may be that they're getting updates that what's working or what they're providing and the treatments that they're receiving are working, but they just don't want to have all the side effects that go along with that any further. Or it may be that they're receiving treatment and they unfortunately have been delivered the news that maybe the treatments aren't working. And so that would be an appropriate time. It also is very appropriate that the patient and family recognize that maybe it's not cancer, maybe it's a diagnosis of chronic obstructive pulmonary disease, or maybe it's heart failure, maybe it's dementia. And that as this patient and family continue through this diagnosis, they are seeing continued decline, continued challenges that are just becoming more and more difficult to encounter daily alone. And so that is always the time to reach out and say, hey, might I be eligible for hospice services? It would allow us to evaluate and see if they're appropriate for hospice services. And if they aren't, that's okay. One of the beautiful things about a ThoraCare Collective is that we are the collective and we have many other service lines that a patient may be appropriate for, and be able to receive services that would allow us to begin and enter into a relationship so that then as they continue down their journey, then we could transition them to hospice, possibly when the time is appropriate.
So you mentioned, having a conversation, and I know over the years, so many people have said, oh, I wish I would have known about this sooner. How do people find out about it sooner?
Right.
I need to go through my doctor, or I can just pick up the phone. I can go. Tell me how it is that if, I'm in that situation, and getting information doesn't mean that I'm making a commitment,
Right.
but it means I'm getting information. And I think because so many people have some fear around hospice, that having that conversation. So how do I initiate it so I don't later say, oh, I wish I would have known about that sooner?
Sure, yes. So there's multiple different ways. We have, first of all, a wonderful website, at thoracare.org, that there is lots of information out there for patients and families, caregivers, community resources. It does not need to be a physician that makes a referral. Anybody can make a referral. So that referral can come from your family physician, it can come from yourself, it can come from your loved one, it can actually come from your neighbor. we would reach out to make sure that that patient and that family are desiring of services. We are also very happy to do what's called an informational session. Anytime that you may have further questions that you do not feel you've gained enough information from our website or other available resources out there, we are happy to receive a phone call and say, can I speak with somebody from the hospice team? And your phone call would be routed, and a message would be given to somebody to call you back and to be able to answer any questions that you have. And as you've said, Risa, it's not just a one and done, or that may have been Gail that said that in terms of the durable medical equipment. Different questions arise at different times for different people. Feel free. That's why we're here. We're here to care for you, the audience, the community, for our patients and families. We welcome conversation anytime. And they are tough conversations. But what we find, as you said, Risa, that patients say, gosh, I wish I would have reached out sooner. It Start having the conversation sooner rather than earlier, rather than later, so that you don't find yourself in a crisis situation trying to make difficult decisions. The first step is really difficult, to reach out and say, I think I need to talk about this, but hospice does have that scary connotation. But we're not scary. We're here to help partner with you.
Right. And actually somebody just sent a question about if there's a quick video that people can look at and to learn a little bit, because it is scary. And I think for different people, based on their past experiences and their current life situations, might not feel that we would be accepting of their lifestyle or accepting of choices. And I think, as you mentioned, our website, there is information about our programs. There is also caregiver videos. There are recordings from these different webinars. There's a wealth of information, and exploring our website, I think, would serve that purpose. And so I appreciate that question. Tracy, want to also check on one other thing, which is sometimes I hear people say that they are choosing not to go with hospice because there's the belief that they can't continue to have their attending physician or their doctor that has cared for them for so many years. It is the case that somebody's physician can stay their physician and work along with our hospice physicians, correct?
Absolutely. We always inquire as to the primary care physician or the specialist, because many times relationships are very strong with a particular specialist, an oncologist, a pulmonologist, a neurologist. We are not there to replace those relationships. We are there to help strengthen them. If that patient requests that provider remain what we call the attending of record, we will reach out to that primary care physician and ask, would you like to be the attending of record, and would you like to provide symptom management? Some physicians are very comfortable doing that. Others are not, but would like to be kept abreast of what's occurring with the patient and family, and we honor all of those requests. And our hospice physicians are there to help provide support to a community physician if they would like to remain involved in the care but need some additional support and guidance.
And we've put in the chat not only our website, but we have some particular a library of videos that talk about what hospice is. And so just additional information. We'll include that as a resource that we'll send out tomorrow. But Gail, I want to spend a little time. We've talked about any diagnosis. We've said wherever somebody calls home. We know that when we think of end of life, it can be difficult to think about somebody young, but we do at our hospice, many hospices, but not all, have particular pediatric teams. And so maybe just tell us a moment about our Kids Path hospice program, really emphasizing that we take care of anyone and everyone that is in need of services.
Sure, thank you, Risa. So it's something that we probably don't like to think about, but we do have a pediatric hospice program that we call Kids Path, and many of you may have heard that title or that word Kids Path, and it means several different things. There's Kids Path counseling, which is counseling for children who are impacted by illness and loss, who are grieving, and that's counseling from a professional counselor. And then we also have uh, Kids Path hospice services for children who are living with a diagnosis or illness that it's considered or determined that they will probably not reach adulthood. So the criteria for hospice for pediatric uh, pediatric patients or children may be a little different than hospice for adults, but we do have the Kids Path program, and there again, there's information on our website about care for children. And again, just like with adults, it's care wherever that child lives and tremendous support to the family and caregivers caring for that child.
Thank you. And then Tracy, I know that you mentioned earlier in our conversation that people often think that hospice means that somebody's life is going to be shortened or that we're going to hasten their death. We do know that there are patients that we believe were eligible and they received services, and at some point they thrive and they may be discharged, which is part of our responsibility to work with that patient family, the physicians involved. And so tell us when somebody might be discharged from hospice services, and then that ability to look at other services within our collective or other organizations to help serve a patient's needs.
Sure. So, yes, sometimes, again, we talked a little bit about burden of medications or treatment. And sometimes, medicine is not an exact science. And so we offer to patients, what we think is the best medical opinion and approach. But sometimes stopping treatment actually allows the body to kind of rest and do what it knows best to do. And so patients will thrive, one, with stopping treatment, but also the intense individualized care that a patient receives on hospice services. So if we see that patient thriving, and which is a wonderful thing, then we will start having conversations about no longer being terminally ill. And we have a collective of services that can help support patients and families. We have a home-based primary care program. We have a palliative care program. We have some specific, very I'm not sure the word I'm looking for, but we have some limited home health services that we are able to offer with other service lines in our program. We also have a CAP program, both for adults. It's called CAP DA for disabled adults, which is a community program. We also have a CAP C program for children living with long-term disabilities. We also have a guide program for patients who are living with dementia and trying to keep them in their home. Patients may also choose to if they come into the hospital and say they've suffered a fall at home and they've had a hip fracture, they want to try to get as receive as much support and mobility back in order to return home comfortably. So patients may choose to revoke a hospice benefit to pursue a short-term period of rehab that will allow Medicare to pay for those services before returning home with the support of hospice services. And then the other reason patients sometimes discharge or leave the hospice Medicare benefit is if they go to a hospital or an area that's outside of our service area. We have contracts. We are currently in 13 counties, and we have contracts with all hospital systems within those counties other than one. But at that time, we will still follow. We do not leave our patients at the time that they come into the hospital. We follow them and offer that continued support, which is unlike some other of our hospice partners in the community. But if we don't have a contract, unfortunately, we do have to ask that patient be discharged. And again, we will still follow and watch for discharge disposition so that we can then provide services and re-enroll you when you come back to your setting.
So Gail, just as we move to the end of our time, I want to be sure that we mention our bereavement services for the primary caregiver after a patient served by hospice does die. Just tell us a bit about that service that I know goes on for about 13 months.
Sure. Thank you, Risa. And earlier, if you recall, we mentioned that often grieving begins prior to death as patients as well as family members, their caregivers grieve what was, how life was before illness, or grieves the many losses of maybe of independence or more stability uh, or and thinking about what life will be like after the death of a loved one. And so the hospice team assist with attending to grief that occurs before death, but then after death, as Risa mentioned, we have bereavement support services available to the primary caregiver, which includes checking in after the death to provide whatever counseling or support may be needed or desired. It could be individual counseling. It could be checking in by telephone. It could be a virtual appointment, just like many professional counselors are currently providing, or it could be coming to our Welcome Center at AtharaCare or our main building to receive in-person grief counseling. It could be a support group. We have many different types of support groups, and not just for individuals grieving who have had a loss due to a hospice death, but other types of deaths and losses available. But we just recently received a beautiful comment from an individual whose wife had died at Beacon Place, and he had participated in all of the above: individual counseling, a widower support group, and just such a testimony of how that care after his wife's death continued and sustained him. And so there again, our care encompasses not just the patient, not just the person living with a terminal illness, but their loved ones, and even after death.
Thank you. And I think that is our place to say thank you to Tracy and to Gail for what you do each day in the lives that you touch. And thank you for participants joining us today. Look for the email with access to the recording and links to resources. And I hope that everybody will be able to join us next month. We're going to gather for our next webinar on Thursday, November 20th at noon, and two of our chaplains, spiritual care providers from AuthoriCare, and we're going to be looking at giving thanks for grief, finding meaning and healing through life's losses. So please look for information, register to join us. And again, thank you for joining us today. And I hope that the rest of the day is a good one. Thank you.
Thank you.
Thank you.